Uh, Good afternoon, Dr. Nunga here. Today we're going to talk about the disturbance of the rhythm of the heart. First of all, we need to know, where does the rhythm come from? It comes from the SA node, or the sinoatrial node, which is right on top of the right atrium. So when it is disturbed, it means something has gone wrong with the SA node. It has been disturbed somehow. What would disturb it? I think I should, follow what I've been doing all along. I've been talking about, a myocardial infarction. And I've been talking about heart attack, so to say. And I've been talking about how destructive heart attack can be. If it can be as destructive as to disturb the right coronary artery, which we regard as one of our fuel vessels. It carries, if that is disturbed, remember we spoke of fuel pipes. We said on the left we have the left circumflux. On the left we have the left descending artery. But today we are not worried about those, because what has been disturbed is what is on the right. So we're thinking about the disturbance of the right coronary artery, which would disturb the source of electrical stimulation, because this electrical stimulation comes from a release of an electrical stimulus or an electrical signal from the SA node. So what would disturb it if there's a heart attack? If in particular, the right side of the heart, the right coronary artery is affected, then the SA node is going to definitely be disturbed, because it is on the right. It is on the right side of the heart. It's right there on the atrium, right on top of the atrium. And it releases electrical signals. And these electrical signals, they move, they form what is known as a wave of depolarization. And they depolarize both atria, the left and the right atria. They spread from that point, from the source being the SA node. What we need to understand by this depolarization, each myocardial cell, be it on the atrium, be on the right, on the ventricle, anywhere in the heart, is a polarized cell. So now, if there's an electrical signal from the SA node, it depolarizes these. And that's the wave we're talking about. It goes right through the atria, both atria, and converges towards an AV node, just like a junction. You know the railway tracks? The railway tracks, they converge toward a junction. And this junction is the AV node, or the atrioventricular node. So there are two nodes here. The SA node, which supplies the electrical signal. We regard the SA node as the battery of the heart. The battery of the heart, because that's where everything originates. You know the battery of a car? You can't start a car if you don't have a battery. So the electrical signals are in the battery, and they have to be released into the car for the car to start. the engine to start and all that, right? So that's exactly what happens in our bodies. We have a battery, the heart battery, which is the SA node. And it releases an electrical signal to depolarize all the atria. And, as a wave of depolarization. And it depolarizes it. And the wave of activation. It depolarizes all the atrial cells, which are myocardial cells, which are polarized, and it depolarizes them. Then a prerequisite of contraction is depolarization. So there has to be this electrical signal that moves from the SA node, and it goes to all the cells of the atria and depolarizing them, so that there should be a contraction of the atria, pushing blood to the ventricles. But then it has got to converge to this junction, the AV node. The AV node. It's got to converge. And the electrical signal is kept there for some time, just a little bit, to make sure that the atria, they finish what they were doing. In other words, the contraction, they finish, everything. They must finish. And then it is released to the ventricle. Now, how is it released to the ventricle? Very important. The AV node is actually connected to a bundle of His. A bundle of His is the one that has got to break off and form the right side, and break off to form the left side. Break off and get to, bundle of His. It's a right bundle of His and the left bundle of His. But the left bundle of His has got two areas. It has got the back area and it has got the front area. Right. So these are the parts. Before everything can be released to the ventricles, it has got to go to these. It's got to go to the right branch of the bundle of His, left bundle of the bundle of His, and the left bundle has got to be broken into left anterior and left posterior. Left posterior. That's important to understand, because we need to locate problems. Is the problem in the left anterior area of the bundle of His? Is it on the right? So this has got to go on like that. Now, when we talk of a disturbance, how does an AV know? How is the disturbance of the? Remember we said what? How is the disturbance of the rhythm? The disturbance of the rhythm, for instance, if it's on the left, on the right coronary artery, it means that there's an obstruction on the right coronary artery. That's the one that gives rise to giving rise to a heart attack on the right side. And that heart attack is going to cause the right, the sinoatrial node to be disturbed, not to be able to release as normal. And it will now go slow in releasing, go slow. And when it goes slow in releasing electrical signals, we call that a bradycardia, a sinus bradycardia, because it's slow in releasing. And the reason we are giving is that there has been a heart attack here. And the heart attack, it was really concentrated on the right coronary artery. And the right coronary artery is the one that is attached to the SA node. And the SA node is definitely affected. So it releases. So there's a bradycardia because of that. But is that the reason? Is that all that can cause that? Even a sinoatrial disease, the SA node, if the SA node is diseased for whatever reason, there are many conditions which can give rise to this. For instance, hypothyroidism, which is a systemic condition. Hypothyroidism will give rise to a bradycardia, but the bradycardia now is not caused by a heart attack. No, it's caused by a systemic condition, hypothyroidism. Hypothyroidism can cause, when there's hypothyroidism, an underactivity of the thyroid gland, and we know that the thyroid gland controls metabolism. So metabolism will go slow now because there's a underactivity of the thyroid gland. So it affects even the rate at which the heart is beating. So it's actually disturbing the SA node, so to say. Right. So hypothyroidism would be one of the reasons. But we need to take history. When there's hypothyroidism, or in fact, when there's a bradycardia, sinus bradycardia, we need to take history. If the patient is a marathon runner, that patient, the heart rate under normal circumstances must be between 60 and 100. If it's below 60, we call it a bradycardia. But now, we need to take history. If the patient says to you, no, I've been running for the last 5 years, I've been doing, marathons and all that for the last 5 years, you'll find that this patient, the cells of the patient or the tissues of the patient will be so used to extracting oxygen. It will extract oxygen such that it will not need a high rate. It will go down because, it's able to, remember, the blood flow, what does the body want from a blood flow? From the blood, it needs oxygen, it needs food. But now, if it's good at extracting oxygen, it will not need that high. It will need just to sustain it for food, but not for oxygen. So you find that a patient has a pulse of 45, 50, and it ends up there. And when the patient is asleep, it can even go to 30. And when the patient is taken to the clinic, maybe the patient is not even taken to the clinic. The patient went there to go and fetch his normal medication for whatever condition. And then the normal procedure at the clinic is to take blood pressure and to take pulse. And they notice that, oh man, it's 35. What's wrong with you? No, let's send you to hospital. No, this patient isn't supposed to go to hospital because this patient is a marathon runner. This is used to this and is fresh. There's no problem. So we need to guard against that. Some patients are just fit. The blood pressure, not the blood, but the pulse is low because the tissues are good extractors of oxygen. And because they're good extractors of oxygen, this is good for the patient. The patient, there's nothing wrong with the patient, actually. You're not going to give any medication for this. There's nothing wrong with the patient. The same as we need to let them recover even from when they have we need to, if we have to use clot busters, those drugs which, do away with clots in a myocardial infarction patient, we can use that. But we are not going to say that the patient, for instance, if it's an uncomplicated MI or an uncomplicated heart attack, we're going to treat the patient, but we don't think that the patient, if the patient is improving, now the flow has been relieved, this obstructed flow has been relieved, the patient can, we can watch that, but that is not a problem now, because the problem is actually solved. But we need to understand that a rhythm disturbance can be caused by quite a number of things. As we say, hypothyroidism, it can cause a rhythm disturbance. But we need to understand that when the patient, for instance, there's a disturbance of the vagal nerve. The vagal nerve causes bradycardia. If there's a disturbance of the vagal nerve, we need to understand that. The vagal nerve is here, on the, goes to the neck and all that. So we should understand why rubbing against the neck, and so, all those things, we should guard against that. That is why people who are hanged, they die. It's because it is the vagus nerve that is actually affected, which will cause a bradycardia, which will even stop the heart. Patients normally who have a bradycardia, they who have a bradycardia, normally they become dizzy. Others get a blackout. Those are the symptoms of people who have a bradycardia. They get a blackout. That's very important to understand. So vagal stimulation could one of the causes. So one has to find out, is there nothing? There must be nothing against the neck, and to make sure that the vagal nerve is not touched, because vagal nerve can cause a bradycardia. So these are some of the things which can disturb the rhythm, and we don't want it to disturb this way. Sometimes you get a fast heart rate, which is a tachycardia, and then a bradycardia followed by a bradycardia, a slow heart rate. We call this a tachybradycardia syndrome. Tachycardia syndrome. So we need to be able to isolate these. Does the patient, of course, the patient is not for us as primary healthcare workers. The patient needs to be sent to the medical department for assessment to say that this is a tachycardia syndrome. Well, I can't say that I'm a doctor, but for me to say that confidently, I've got to report it to the specialists, like the physicians, like the cardiologists. Is this a tachycardia syndrome? What's happening here? What is happening here? And we need to find out. We need to establish whether there was a myocardial infarction before, or a heart attack, because if there was a heart attack, we want to establish how was the right coronary artery. Right coronary artery is the one that will be affected directly. It will affect the SA node, which is the sinoatrial node. That is where my electrical signals come from for depolarization of the whole heart. Depolarization of the whole heart. To depolarize the whole heart, I need no disturbance of the electrical signals that is released by the sinoatrial node. It must depolarize all the atrial cells, and then converge to an AV node, and then it's kept there for some time, a little bit, just to make sure that the atria has finished its contraction. The atria, just to wait for the atria to finish everything. Then you wait, and then release the signal to go to the ventricles. Of course, it doesn't go to the ventricles initially. It goes to the bundle of his, gets to the bundle branches. Bundle branches, you've got the right side and you've got the left side. And you know that the left side has got the back portion, which is the posterior, and it's got the front portion, which is the anterior portion. And these must be, and we want to make a difference and know that this is the anterior bundle branch block, if there's a block there. Remember, when we've got to trace blocks, we've got to know whether it's a right bundle branch block or a left bundle branch block. If there is a block, we need to need to know that there's a right bundle or a right bundle of his and there's a left bundle of his, because we want to be able to trace our blocks, which side is it, and it's important to be able to do that quite well, because it helps to treat the patient. It helps to treat the patient. So this is what we need as a complication of a heart attack: rhythm disturbance. And the first rhythm that what is discussing is a bradycardia, a sinus bradycardia, and we have to find out which one exactly is it. Is it a sinus? Is it a problem of the sinus SA node? A disease there? Or is it because of a myocardial infarction? Maybe an obstructed right coronary artery? We need to know that. We need to know that so that we can go with our clot busters to the coronary artery and try to and relieve the patient from this obstruction, because that can cause the problem. It can cause a bradycardia because what is released by the is actually not getting to where it's supposed to go to. It's not getting anywhere because it is obstructed. So these are the things we need to find out. Is there a systemic? Well, we can do TSH, thyroid stimulating hormone. Find out. Once you know TSH, your thyroid stimulating hormone, the levels, you will know that if you have a hypothyroidism or not. In other words, and that will help, because you'll be able to know now that, oh no, it's because of the levels. For instance, it's because of the underactivity of the thyroid gland, and that is why we have a slow heart rate. It's important to know that. It's important. I mean, you can solve the problem. At least you won't be able to say, oh, no, this is a tachycardic syndrome. No, it's not that. It is because of the thyroid gland that is underactive. Right? So basically, these are the things so the disturbance that we are looking at today, we're looking at a bradycardia. We need to know, is this a marathon runner? Is this an athletic run? Is it an athletic guy? And this is not a patient if he's an athletic guy. I mean, this is not a patient. This is just a person who is looking after himself, and this is very good that he's doing this. But I noticed that his heart rate is 35. And this is shocking to me. It should, once you get, the history that he has been a marathon runner for the past 10 years or something like that, you got that kind of history, then you know that the tissues of this guy in front of you are used to extracting oxygen, and that is why he's got a low heart rate. Thank you very much. I'm glad if you learned something from this. It's often very confusing to get a blood pressures, you get a pulse of pulse of 35, pulse of 40. That's odd. That's odd. But if you have a history of this guy being a marathon runner or this lady being a marathon runner, then it gives you the explanation that the tissues of this guy in front of you, they're very good at extracting oxygen, and so they don't need a high pulse rate. Thank you very much. Bye-bye.